great pleasure to meet you all, and it's very nice to see you. I'm Paola Nicolaides. I'm a pediatric neurologist currently working in Cyprus after many years as a consultant in the UK. Together with Michael Baritza, I had the privilege of describing the first patient with what then became known as the Nicolaides-Baritza syndrome. I'm delighted to join you online for the NCBRS Going Global Family Conference in the USA today. This weekend is a wonderful opportunity for families, professionals, and researchers to connect, share experiences, and learn from one another. A special thanks goes to Lee, Nuala, and all the organizing team for their dedication in putting this together. And along with our geneticist, Stephanie Efthimiou, we'll be offering a one-to-one online sessions for families who'd like to discuss specific questions outside of this conference. So please contact Lee if you're interested. And I hope this weekend brings you inspiration, connection, and renewed commitment to improving the lives of individuals with NCBRS. Next slide, please. So at the heart of this weekend is our shared mission to create a global community where families, healthcare professionals, and researchers work together to ensure that every person is diagnosed with NCBRS is able to have the opportunity to reach their full potential. This vision guides us, unites us, and reminds us of the strength that we have when we come together. Next slide, please. This slide provides a brief overview of what I'm covering today. I'll begin with a short introduction and background before giving you an overview of the syndrome. Then I'll highlight some of our key clinical findings from the most recent cohort presented at the EPNS, it's the European Paediatric Neurology Society meeting that we had in Munich in July 2025. And next, I'll briefly discuss some broader medical aspects that affect individuals with NCBRS, alongside with some therapeutic interventions and early support services. And finally, I'll conclude with some reflections on future directions and ongoing research. Next one, please. So can you please press again, please, so that we can have, and again. Thank you. So when you hear Nicolaides-Baritza, you've already met me now. But I really wish you could have met my colleague, Michael, which is the other half of the name. I'd like to say a few things about Michael. He was born in South Africa, in Cape Town, in fact, and he studied agriculture initially before changing into medicine. And then he moved into the UK for a safer life with his family in the 1970s. He trained first as a neurologist, and later he was got into genetics, and he worked at the Kennedy Galton Center first, and then he became a consultant at Great Ormond Street, where I had the privilege of meeting him and working with him in the early 90s. He was a remarkably intelligent and incredibly sharp and kind. Over his long career, he published hundreds of papers and co-wrote several books with Professor Robin Winter. And together they founded the London Dysmorphology Club and the London Database, which were really truly pioneering at the time. But more than his achievements, what really defined him was his warmth and his connection with patients and the families. He had a quiet brilliance and deep humanity. I felt really privileged to have known and worked with him, and he remains an enduring inspiration. Next slide, please. And again, so in 1992, Michael and I met June, a truly special young lady who became the first patient, a published case of what we now know as the Nicolaides-Baritza syndrome. The discovery wouldn't have been possible without her mother, Ruth, whose unwavering determination to find answers for her daughter allowed us to recognize and define the syndrome, and eventually to understand its underlying cause. June was born in 1975. She was small for gestational age. She was 1.8 kilograms at birth, and she spent several weeks in intensive care. Early development was slightly delayed, and at around 3 years of age, she began having seizures, unfortunately, and these continued throughout her life with varying intensity. She was initially seen in Sheffield and later referred to Great Ormond Street, where she met Michael and myself. She sadly passed at the age of 35, but her story and family's dedication have left an enduring legacy that continues to inspire our work and benefits countless others with NCBRS. Next slide, please. This is a slide, and can you press again, please, so we can have the, and again, and again. So this is a slide of June's photographs. I thought it would be nice to show them to you. She's at different stages of her life, but what's unique is that she's always smiling, full of warmth and energy. Despite the challenges she faced, she radiated happiness and a real joyful life. Her mum once wrote something that truly captures who she was. Being June's mom, she said, was a blessing, a humbling experience. People like ours with NCBRS can teach others so much, to appreciate what they have, not to complain when things don't go as hoped, but to make the best of every situation. And if June could speak to her NCBRS siblings today, I think she'd say, sure, I had many of the symptoms, mostly at the severe end, but you know what? I really enjoyed my time at the fun fair of life. And as you can see, she was doing different things at different times. Next slide, please. So, and again, so what is this syndrome? What is NCBRS? First of all, to say it's ultra rare, it's an ultra rare genetic syndrome. The name is proposed in 2003 by Maureen and colleagues in recognition of us as authors describing June in 1993. The syndrome is characterized by developmental delay, most prominently affecting language and intellectual abilities. There are also some dysmorphic features that I'll describe later on, with sparse hair. Epilepsy is very common with various seizure types, as well as short stature and prominent interphalangeal joints and the distinct facial features. NCBRS is present from birth. It affects both boys and girls and is usually recognized in childhood. To date, there are around 100 families being described patients in the literature, but the actual number is estimated to be around 330, but we think that's an underestimate. It is important to note that the physical features and medical problems vary between individuals, which can make the diagnosis more challenging, and this requires tailored clinical follow-up for each patient. So why does it happen? So NCBRS, the underlying cause is a mutation or a variant in the SMARCA2 gene, which is part of the BAF chromatin remodeling complex. This complex plays a crucial role in DNA and how it's packaged and accessed in our cells. Specifically, the SMARCA2 gene is involved in chromatin remodeling, a process that allows certain genes to be turned on or expressed. And without proper remodeling, important genes might remain silent. SMARCA2 is particularly important in neural development, which helps explain the neurodevelopmental features of the condition. And the gene is located on chromosome 9 on 9p24.3. It's important to note that standard chromosome analysis appears normal in all patients, so more advanced genetic testing, like exome sequencing, is required to identify the mutation. And next one, please. And again, so this is the diagram that shows the most mutations in this SMARCA2 gene, where they're found. They cluster in key functional areas, especially the ATPase and the helicase domain, which is important for chromatin remodeling. And this means that mutations here are more likely to disrupt how the gene works and lead to the features of NCBRS. The pattern helps researchers understand why variants are likely to be pathogenic. Stephanie will be expanding further on the genetics of NCBRS in the next presentation, so I won't be saying too much else on that. Next one, please. Just to say that NCBRS is inherited in a dominant, autosomal dominant manner. To date, nearly all affected individuals have had a de novo, and so a new pathogenic variant in the SMARCA2 gene, meaning that the variant arises spontaneously in the affected child rather than being inherited from a parent. Although no confirmed affected siblings have been reported so far, we are currently looking into 1 or 2 families that have recently been brought to our attention where this possibility is being investigated. The recurrence risk for siblings is therefore considered very low, but maybe slightly higher in case in the general population due to the theoretical chance of germline mosaicism, which is in one of the parents. If SMARCA2 pathogenic variant has been identified in a family, prenatal testing can be offered for pregnancies at theoretically increased risk. Next one, please. So the diagnosis is confirmed through genetic testing. Blood sample is analyzed to sequence the gene where pathogenic variants are responsible for the condition. When a new variant is identified, it's important to determine whether it's also present in either of the two parents. In almost, as I've said before, in almost all reported cases, this hasn't been found. So sometimes NCBRS may be diagnosed incidentally, so through broader genetic testing, such as whole exome sequencing, looking for other things, or whole genome sequencing, which examines nearly all protein coding genes. This approach has become increasingly common in children with developmental delay or epilepsy. Before the SMARCA2 gene was identified, diagnosis relied clinically on clinical features and excluding other syndromes, for example, like Coffin series, with overlapping some characteristics which were similar. Okay, moving on to the next slide, which is the sort of the facial characteristics. So the facial appearance in NCBRS is quite characteristic and can often provide an important clue to the diagnosis. Typically, the face looks a little bit triangular with dense eyelashes and a prominent nose with broad nostrils. The lips are distinctive. The upper lip is thin and the lower lip is fuller, giving a mouth a broad appearance. These features tend to become more pronounced with age. In younger children, they may be subtle, but as they grow, loss of subcutaneous fat in the cheeks makes the skin appear looser and more wrinkled, which accentuates the facial phenotype. Recognizing these evolving facial features can be extremely helpful in distinguishing NCBRS from other syndromes and in guiding genetic diagnosis. Moving on to the other features, dental individuals usually have widely spaced teeth with both baby and adult teeth showing delayed eruption. This can sometimes lead to feeding and orthodontic difficulties later on. The hair is very characteristic, and it's really one of the signs of NCBRS, the sparse hair, which is what we recognized in June, and is present in nearly all diagnosed cases. Although the texture and growth rate may be normal, the sparseness may change with time, becoming either more pronounced or in some or with improving slightly in others. In adult males, facial hair is also usually limited. The skin is also important. Around 1/3 of individuals may have eczema or increased skin sensitivity. This can add to daily care challenges, but is not usually a major medical concern. When these features are seen together with the facial appearance, they could strongly suggest a clinical suspicion of NCBRS, and that's how you should get guided for genetic testing. And moving on to the other characteristics, which is really looking at the hands and feet, the extremities, basically the fingertips become broad, the interphalangeal joints appear more prominent, and these again are increased with age as more characteristic signs. In the feet, there's more of a gap in the sandal gap between the first and the second toes. There's also progressive thickening of the distal toe tissues, most noticeably affecting the fifth toe. Hearing loss is relatively uncommon, but it may occur, and it sometimes is conductive in type rather than sensory neural hearing loss. But they sometimes get recurrent ear infections. In terms of vision, some individuals experience some visual problems, with myopia, astigmatism being the most common of these. And therefore, ophthalmology follow-up can therefore be helpful for ongoing care. And finally, if you look at all these things, they do tend to vary within individuals. Next slide, please. So in terms of growth, many children have low birth weight, and a similar proportion have short stature. None of the reported individuals were above the 50th percentile for height. Microcephaly, which is a small head, may be seen is typically acquired rather than present at birth. And it is noted that about 1/3 of infants at birth and in 2/3 are at follow-up. And yeah, so next one is a little bit about there's some arthritis and scoliosis is commonly seen. So it is worth looking into these when children are diagnosed with the NCBRS. And there are some rare features. In the next slide, you will see some sort of hernias appearing. These are either groin or umbilical hernias. There's undescended testes are quite common in boys, obviously 60% often requiring surgery. Mentioned the scoliosis in 1/3. Cardiac problems, not so common. However, some have been reported: double aortic arch, mitral valve regurgitation, and thickened ventricular septum. So this makes cardiac assessment also important, especially at diagnosis. And other features may include rare sort of renal things like vesicoureteric reflux or low renal abnormalities are not commonly seen. Sometimes they are seen, but it could be coincidental. Mild dyslipidemia may also be seen. So this reminds us that NCBRS is not only a neurodevelopmental disorder, but can also affect multiple organ systems, emphasizing the need for the multidisciplinary care. The next slide, just to mention about epilepsy. I know this is another presentation later on about epilepsy, so I don't want to say too much about it, but it is important just to mention it for completion. Around 2/3 of individuals with NCBRS will experience seizures, although the type of seizure can vary between individuals. The average age of onset is between 1.5 and 2 years, but seizures may begin at birth or as late as 14 years. This is important to note. In some cases, seizures may become more frequent or harder to manage over time and may require many anti-seizure medications to be used. People have used sodium valproate, levetiracetam, oxcarbazepine, topiramate, lamotrigine, various anti-epileptic drugs. There is not a gold standard one to use. Some children also will develop some regression of developmental skills and language that may be seen in association with epilepsy, suggesting that seizure activity may influence cognitive problems. So one of the main challenges is that seizures are often difficult to control completely, and in some individuals, they may become more refractory with age, requiring combination therapy. So next one is a little bit about status epilepticus. Okay, as I say, if this is episodes of seizures that go on for more than 30 minutes, it is a difficult type of seizure to manage. It is metabolically very demanding on the body and brain and can result in permanent brain damage. So it is important to be aware of it at least and to have emergency medication available. If this were to be the case, you will hear more about epilepsy in the next talk. Thank you. Next one. The development is an important concern, as it is quite common for children to present with developmental delay and following that intellectual disability. As you can see there are most individuals have been diagnosed with intellectual disability and more on the severe and moderate end of the spectrum rather than mild, although these figures are not accurate because formal IQ assessments cannot take place in these individuals for the various reasons, including their behavior and lack of concentration. And currently, we are looking to see if there's any gene variation that and phenotype variation that can predict expected delays and degree of intellectual abilities. Speech can also range from absent in 30%, limited to conversational, and speech decline may be seen in relation or not to seizures. So next one is how it affects intellectual disabilities. As we've said before, 1/3 can have moderate and the remainder severe or mild to moderate to severe intellectual disability. There is a spectrum there. Psychomotor regression is not typical, but it does occur. it is good to be aware of these difficulties when looking after these individuals, so that we can provide them with what they need to meet these difficulties and behaviors, including the autism spectrum. I'll show them in the next slides, please. Yes, so in terms of common strategies, how to manage these things, because individuals with intellectual disabilities, they use different strategies like avoidance when faced with tasks. They may withdraw, they may resist change, they lose interest. Their problem-solving abilities are less efficient than others, making it harder for them to apply strategies flexibly across different situations. They also have a difficulty consolidating new skills. They may learn something in one context and then struggle to generalize or use it consistently in others. Over time, this can lead to reluctance to take initiative and learning activities, sometimes appearing as passive, dependent, or giving up easily. So their response with courage can also vary. At times they respond well to positive reinforcement, but other times they may remain disengaged despite support. Well, these observations highlight the importance of structural teaching, patience, and consistent reinforcement to help children with intellectual disability build their skills, confidence, and motivation. So next one, please. So in NCBRS, there are several reasons why they may get a decline in their IQ scores. One key factor is the uncontrolled epilepsy. Frequent seizures and prolonged episodes of status epilepticus can interfere with attention, memory, and learning, sometimes leading to cognitive regression. Another contributing factor is the slow development of speech and language. Since communication skills form the foundation for learning and social interaction, delayed speech can make children appear to fall further behind as they grow older. The encouraging news is that early intervention can make a real difference. Some reports suggest that timely therapy and support can help stabilize or slow the decline in measured IQ. Speech and language therapy is particularly important. I have another slide further on, not only for improving communication, but also for enhancing overall cognitive development. This underscores the importance of early recognition, monitoring, and prompt referral. In terms of the behavior, as you all know, commonly children may show challenging behaviors, although the type and severity may vary. They do have temper tantrums, periods of aggression, often linked to frustration, particularly when communication and language skills are limited. Many children have short attention span. They are easily distracted. Some show sensitivity to loud noises, whilst others have an unusually high pain threshold, which may delay recognition of injury or illness. Oral sensitivities are also noted, with some children preferring strong tasting foods such as salty or spicy items. Although feeding problems are less frequent, they can occur in a few individuals. And a little bit about sleep. These are quite common, the disturbances including night waking, and they're commonly seen. Some children may have these persistent behavioral difficulties, sometimes overlapping with the autism spectrum behaviors, repetitive behaviors, etc. So again, early behavioral support, structural routines, and consistent communication strategies are key in helping families manage these difficulties consistently and effectively. And a little bit about the autism. The next slide, please. Many individuals will ask us whether you have children with NCBRS have autism as well. They do show autism-like behaviors, such as difficulties with interaction, communication, and repetitive behaviors, although most do not meet the full criteria for the ASD. There is a clinical overlap between NCBRS and autism, reflecting shared features in social and behavioral development. At the genetic level, variants in BAF complex genes, including the SMARCA2, are linked to a range of neurodevelopmental conditions, including the Coffin series syndrome, NCBRS, and autism, suggesting a shared biological pathway involving the chromatin remodeling. Clinically, while not all children with NCBRS are in the spectrum, many may still benefit from autism-focused interventions, particularly in social communication and behavioral support. And next one is leading on now to our work that was presented at the EPNS conference in Munich. This is relating to the largest international cohort of individuals with the NCBRS. It's work in progress. This study, we explored how different SMARCA2 variants correlate with both neurological and morphological features, helping us better understand how the genetic changes shape the clinical presentation. Importantly, these findings may also inform future therapeutic strategies and improve targeted care for affected individuals. Next one, please. So we assembled the largest NCBRS cohort to date, 185 individuals through ClinVar, GeneMatcher, and NCBRS Foundation referrals, and thanks for that. We reviewed clinical and genetic data, including developmental milestones, seizures, facial features, and the SMARCA2 variants. The cohort comprised 60% male and 40% female, consistent with previous reports. And this represents ongoing collaborative work. We haven't quite finished yet with the University College London. And I'll give you some of the results from this study so far. Next slide. Doesn't show there. So as previously mentioned, facial features are often considered a key diagnostic clue in Nicolaides-Baraitser syndrome, though their expression can vary, particularly in younger children or those with a typical genotype. To standardize phenotypic classification, we use quantitative dysmorphic scoring system. We classified the core features: the sparse hair, triangular facial shape, wide mouth, and a thick lower lip, and each were assigned 1 point. And the secondary or subtler features, including coarse facial features, thick eyebrows, or narrow bridge, were given half a point. And when classification was based on core features alone, most individuals, 70 out of the 185, were placed in the mild category. However, after including the secondary traits, 24 cases were reclassified, mainly from mild to moderate or severe. This finding underscores the importance that while core features are essential for identifying the syndrome, secondary characteristics significantly refine phenotypic assessment, particularly in cases where the diagnosis may not be immediately obvious. And I'm sorry you can't see the table there. It showed the different scoring systems. Obviously didn't come through well when the slides were sent. The next one, please, refers to the skeletal abnormalities. Skeletal involvement, as I said, was also a consistent but variably expressed feature of NCBRS, mostly affecting distal extremities and spine. To assess severity, we applied a skeletal scoring system based on 3 key features: scoliosis, prominent distal phalanges, and prominent interphalangeal joints. And we scored each core feature with a 1 point, giving a maximum total score of 3 points. And we had 6 individuals that had 1 feature, 50 had 2 features, and 20 individuals had all 3. This distribution highlights a graded skeletal phenotype, with many individuals showing moderate involvement. And the third one is looking at epilepsy and seizures. Next slide, please. We also looked at epileptic seizures, were reported in 70% of the individuals. Using the criteria, the ILE criteria, we noticed that the most frequent type were generalized tonic-clonic seizures, followed by focal seizures with impaired awareness. So notably, early onset and drug-resistant epilepsy tended to occur in individuals with hotspot variants affecting arginine residues in the ATPase domain, particularly at positions arginine 115 and arginine 1108. These findings support the idea that residue-specific alterations may disrupt neuronal excitability through impaired BAF complex regulation. And next slide, looking at intellectual disability. Almost all individuals exhibited moderate to severe intellectual disability, though clear stratification was observed based on variant location. We had some information missing. If you will see, the one with the star is the individual ID with no specification, and the developmental delay at young age. So variants within the ATPase domain, particularly again in helicase seed subdomain, were linked to a more profound developmental delay and frequent absence of expressive language. In contrast, individuals with variants outside this region often retain limited but functional speech, suggesting partial preservation of SMARCA2 enzymatic activity. So the next one is just a summary saying that the main clinical features reported are shown here. As you can see, the sparse hair seems to be there in 97%, and the joint abnormalities in 85%. Epilepsy is strong, intellectual disability, speech delay, behavioral issues, and the less common features as shown in this slide. And moving on to management, just to say that management needs a truly multidisciplinary approach, as these children often have complex and varied needs. Early intervention is key. It's involving speech and language therapy, occupational therapy, educational support tailored to each child's individual abilities. Seizure controls remains also one of the main priorities, requiring close follow-up with pediatric neurology services, since medication plans often need ongoing assessment and adjustment. Behavioral support may also be needed for issues such as poor attention, aggression, or autistic traits, and developmental pediatrics can offer structural strategies and guidance for families. Nutritional support is important as well, as some children have feeding difficulties or growth concerns. A dietitian can help monitor weight and optimize nutrition. Overall, coordinate care is essential, with the pediatrician playing a central role in linking all services and ensuring families feel well supported. Next one, please. The early intervention is vital in managing children with this condition. It maximizes developmental potential and support families. We've mentioned speech and occupational therapy, physiotherapy, educational input, special needs programs to address learning challenges. Speech therapies also improve non-verbal communication. Parent education is absolutely essential. It empowers families to advocate effectively for their child, as parents are the real experts in the child's care. And this is why you're all here today, to learn from each other, to share experiences. So it's important to remember that the intensity of early intervention does not always predict better outcomes. What matters most is that therapy is consistent, appropriate, and family-centered. Next one. So language development is often limited, as we've said, and one of the most challenging aspects of the condition. 30% of individuals never develop any speech, while those that do typically say their first words after 18 months may have restricted speech, restricted to single words, or repetition, echolalia with unclear articulation being common. And about 15% may initially lose their words or experience a type of reduction in vocabulary, which may be related to the onset of epilepsy or the autistic features. So these findings highlight the need for early and ongoing speech and language therapy, alongside alternative communication methods, which are very important in these cases, of course, sign language, symbols, electronic aids, and to help children express themselves more effectively. And the next one. So when supporting children with intellectual disabilities, we need to focus on practical communication and social skills, teaching to express their needs, help reducing frustration, encourage positive interaction, nonverbal communication, such as facial expressions, gestures, and body language, is equally important for understanding others' intentions and emotions. And interactive play plays a valuable role as well, giving opportunities to practice turn-taking, sharing, and building relationships while redirecting repetitive behaviors into more meaningful activities. By strengthening these areas, verbal, nonverbal, and interactive, we promote independence, inclusion, and social connection. Next one. So the motor skills, most children with NCBRS achieve basic motor milestones such as walking, sitting, though later than typically developing peers. With practice and support, progress continues, but the rate varies greatly. Some children achieve mobility early, whilst others need prolonged physiotherapy. Balance often develops more slowly than strength, affecting activities like walking, running, or climbing. In older individuals, they may gradually slow, highlighting the importance of continued physiotherapy and regular physical activity to maintain the children's or the individual's mobility and independence. So physiotherapy, next one. Physiotherapy plays an important role in managing children with NCBRS. Though expectations should be realistic, it may not help children walk earlier, but it improves the quality of movement and prevents long-term complications. Therapy helps avoid poor posture, such as turned-out feet or lordotic gait, and supports better balance, coordination, and confidence. Group sessions can be especially valuable for older children, combining physical improvement with social interaction and motivation. Overall, physio enhances posture, movement, and participation in daily recreational activities. Next one, occupational therapy focuses on promoting independence in daily activities. Key goals include developing self-care skills such as feeding, dressing, and hygiene, which build confidence for both children and families. Therapists also support school-related activities like handwriting, tool use, and attention, helping children participate more fully in education. Play and leisure are also important, encouraging social interaction, problem solving, and coordination. OT often overlaps with physio and speech therapy, as posture, coordination, and communication goals are all interconnected. Overall, OT helps children with NCBRS gain greater independence and participation in home, school, and community. Okay, so next one, please. In conclusion, there is no single method that suits all children with NCBRS. The aim is to focus on what is most meaningful for each child, whether that's communication, self-care, social skills, or behavioral management. Social and communication skills are especially important as they underpin emotional well-being, relationships and learning. Civil behaviors like cooperation, waiting, and managing frustration are also support success in school and daily life. Flexibility is key. Speech therapy, sign language, occupational therapy, behavior support may all be used at different times. The ultimate goal is to help the child progress socially, emotionally, cognitively, and academically. And the next one, looking into the future, where are we going? There are several key research and clinical priorities in NCBRS. Firstly, we need a clearer understanding of how different S-marker gene variants relate to the clinical picture. Establishing stronger genotype, phenotype correlations would allow us to predict disease severity and guide prognosis and management. Second, the connection between seizure onset and language development remains a critical area of study. Whilst we know that epilepsy can influence both cognitive and speech outcomes, the timing and underlying mechanisms are still poorly understood and are being investigated. And finally, advancing our knowledge in this marker 2 at the molecular level may open pathways for targeted therapies. Because marker 2 plays a role in chromatin remodeling, future discoveries could lead to interventions that modify gene expression, an important step towards precision medicine. Overall, ongoing research will help move the field from supportive management towards more personalized and therapeutic approaches. Next one, please. So this brings me to the end of my presentation. I'd like to once again thank everyone, the NCBRS Worldwide Foundation, the organizing committee, and most of all, the families, the parents and their children, for allowing us to progress in the understanding of this very interesting syndrome. Thank you very much.